Did.
Perfect. Thanks, Rana. Don't worry.
Well, thank you for your patience. Thank you.
So,
I
Rep
guess,
Johnson, can you please repeat what you had said regarding the rally in
Yeah,
Hartford?
it's a press conference, not a rally.
Sorry.
So no worries. And State Senator Saud Amora, he is going to be putting this together with a number of people at the Capitol and people who are supporters of making sure people have good access to health care coverage. And so this is something that he wanted to do, is something I've been working on as the subcommittee chair of the Complex Care Committee of the which is the Complex Care Committee of the Medical Assistance Policy Oversight Council. And it's something that we had the Center for Medicare Advocacy come and talk to us about. But also, we've had a number of difficult situations with regard to the, I like to, I joke, I call it the disadvantage plan. Because it has done so many things that are not, you know, helpful to the people, and the advertisements are just amazing. I've had a number of people who have run into a lot of difficulty. Primarily, the networking is very, very, very bad. They're supposed to supply every single thing that regular Medicare fee-for-service provides. Plus, they always say we have dental and hearing and vision. But as a general rule, their networking is somewhat deficient. And sometimes they don't provide everything. And by the time the person gets through whatever medical crisis they were in, provided they survive, then it's hard to go back and make sure that they pay consequences of some sort because they didn't have the proper networking availability for that particular person. So we'll be talking about those kinds of things and whatever else people have to bring to the conversation, but making sure that they're supposed to do what they're supposed to do in accordance with the law, and having that part of it function is a function of the federal government, but it's also a function of state government when they allow the advantage plans to be utilized with the Medicare Savings Program, which is a huge problem because there's really no need to have an advantage plan if you have the Medicare Savings Program, which covers all your coinsurance and deductibles amounts. So that is another thing that people are spending money on this, and they really don't need to. And then they run into problems again with access to services that they should have, that if the network is inadequate, it's a problem. I see Donna Nicolino seems to have a hand up. Hi, Donna. How are you, neighbor?
hi, Susan. Good to see you. So perhaps I missed this, or I'm just trying to wrap my head around the policy part of it. But so what power does the state have to regulate the Medicare Advantage plans? I mean, I know obviously Medicare is federal. The Advantage plans are privatized, so they go, to the state, different state level insurance companies. So like what could happen? Like what might the state be able to do in
Well,
terms
what they had done, and back in the day when I worked for the Center for Medicare Advocacy, we would appeal the denials. Now the denials are done with a lottery basis instead of based on every single person that's denied. And so the center lost a lot of client capacity with the lotto system. And so there isn't that. We also have now not just the Center for Medicare Advocacy, we have the Office of the Healthcare Advocate. And they do the same thing the center did, only they cover not just Medicare, they cover private insurance, health insurance, the Affordable Care Act insurance, all different types of insurance policies. So that's another place that could go as oversight for these cases. The problem, I think, what we have is getting people to complain and knowing that they have a place to go to. and losing out, and then just kind of forgetting about the fact that they ran into a problem. They couldn't get physical therapy or home care services, even though they were supposed to be homebound. But they took a risk and went out when they shouldn't be going out, and could have gotten more injuries because they had to get the physical therapy on an outpatient basis. So that is a huge problem. And if in fact you had the denials, then you would be able to get that feedback. But that was done away with after I left the center. I don't know how it happened or anything, but so that's a good question. And it was be something that one of the things I like to do with in the complex care subcommittee is to look at cost shifting, because one of the things I found out when I was chairman of public health is a lot of these organizations like to shift the cost from one place to the next. So even the good old federal government wants to shift the cost to the state. So for example, if it's a Medicare claim, yet the person gets themselves in a situation where they no longer qualify for the Medicare part in the coverage, then they'll be transferred to the Medicaid program, which is mostly state. That's all state operated. Even though we get 50% reimbursement, it's not the same as Medicare paying the whole 80% or 100% of the cost of the care. And you can see this with workers' comp, you can see this with private insurance companies, you can see this sort of thing. And with the Advantage plan, it's even more difficult. As you mentioned, it's privatized. And so to try and get data from the private entities is next to impossible unless we may have the federal government make a contract. So we'd have to get the data on the back end with the denials if we had everybody that was denied go through the process. Or we have, and the other thing about this, even if you did, a lot of the times with the Advantage plans, the appeal system is completely different from the appeal system with the fee-for-service plans. So you have that problem as well. And so you might have a doctor that disagrees, but the doctor's part of a group like Hartford Health, and the doctor is not going to maybe really fully get how they can push to get the coverage. They go through the process of talking to the insurance company, or the trust company, because it's not really insurance, and they will a lot of times push for whatever it is. It's a standard type of coverage. But if you have something that might be good for you and it's a little bit different from what everybody else is getting, it's going to be very hard for the doctor to convince the insurance company to pay. I mean, I think I digressed a little, but
It's good information. It's a lot, and I can understand, you said that people often don't know about like how they can appeal or what the possibilities are. And I think, the system can be so overwhelming and so kind of in the weeds that a lot of people just, they have a hard time with it. So they give up.
yeah, they do. And that was the whole idea behind the insurance companies doing it the way they do, because they know that they'll give up. They know that they have the data. They don't share the data, but they have the data.
Right. Yeah, thank you.
Sure. Thank you. But it'd be good to get everybody involved in the press conference on this issue, on the Advantage plans, because the state has put all the retired employees on Advantage plans. And so you have all the state employees here. Now they're different because they don't have the network requirements that say a local Advantage plan would have. So if you sign up locally as an individual instead of with the state, for example, as a retiree, you're going to be subject to the limitations of whatever that Advantage plan networking is, even though they shouldn't be, there should not be any difference. But with the state employee retirement plans, the network requirements aren't there. So they can go all over the country. But here's the other thing about that. There's always something else, isn't there? The other thing about that is, and this has been more noticeable perhaps in California than in Connecticut, but I think we're getting to know more about this. And that is, a lot of providers now won't accept Medicare Advantage plan people. they're turning them down. And so, and they have the right to do that. So they're going to turn down the Medicare Advantage plans, and they're doing it in California a lot because of the way that they reimburse, the way that they deny. So people, and I even had it happen to me with my glasses. I went to a provider for my glasses, and I know that I'm supposed to get a little bit of coverage for that because of these changes. And I have an Advantage plan that says that they'll cover it, but the doctor's office refused the Advantage plan coverage. So that's coming, and it's an optional thing. So I could go to another place for the glasses that might accept the Advantage plan payment, but that is also something that's quite different than how it's explained on television.
I wanted to deal with that issue. For those of you who don't know, before I retired, I worked in the state controller's office, managing the state employee medical plan for actives and retirees before we had Medicare Advantage. And I've been lobbying and trying since they started with United Healthcare to get them to stop that. The problem is, of course, is the state is saving probably $500 million a year because the feds are paying for it. So opposite to what you just said, Susan, right? Where the feds are wanting the state to pay on the Medicaid side. On this side, the state is at a big advantage because the feds are paying more. Stephen, you're going to have this when you retire, when you're on Medicare. Right, you shake your head. And your network, is correct on the network. I did have, by the way, one example of that. I got referred by my dentist, which is not under Medicare Advantage, to a dental surgeon, right? Which is covered by Medicare under the plan. And they refused that the provider that I was referred to, who participates in Aetna Medical, refused to see me, saying that they didn't accept Medicare patients. Exactly what you were talking about, right? So that's one of those glitches. I found another provider who was able to do it. The other part was I was scheduled for surgery on a shoulder. It got denied by Aetna. They told the surgeon that it was not appealable. I said, yes, it should be appealable. They did it. They went through the first stage of an appeal, which basically is somebody from Aetna sitting down with somebody from the doctor's office, didn't look at any x-rays, didn't look at the MRI, didn't talk to the surgeon, right? And they denied it and said I had to go for 6 weeks of physical therapy first, which I had done 2 years earlier and got when the surgery was originally scheduled. But Aetna didn't have those records because that was under United. And the surgeon didn't have those records because the physical therapy was under Gaylord, which isn't on my chart. So we have this integrated system which isn't integrated, right? That just and decided not to have the surgery for other reasons. So worked out good. But we really have to figure out a way to deal with this. The state employees are in preliminary negotiations now with the state. All these state employee health contracts expire in June of 2027. And at this point, from what I've been able to tell, the unions are not interested in getting rid of Medicare Advantage. Most retirees, but I'm also treasurer of the local chapter of the retirees of CSCA. Most people are very happy with it because, as you said, we have no network limitations, right? The benefits that we have are exactly the same as we had when we had Anthem or the other, whatever company we had, Health Pro, because our contract with Aetna and with United was that basically they had to follow the same benefits that we had, which was basically Medicare, and then we had a Medicare supplement plan. And so we basically have a wraparound plan with Medicare Advantage. So when I get my Medicare D monthly bullshit paper, excuse the language, waste of paper, it goes in the waste basket or recycle. All it shows is what's covered by the plan, and then that's what's covered by the supplement plan, right?
Bill,
So-
I don't want to interrupt you, but
Yeah,
and I don't mean to be rude,
no, that's
but
okay, I'm finished.
the majority of us who have experienced Advantage plans and those who are not on a state plan, who do not have contracts that are negotiated, it is a nightmare. It
Oh,
is
I totally
true
agree.
and complete nightmare. So I would really appreciate it. And I think those of us who have had horrible experiences with Medicare Advantage, I would be grateful if when you spoke to the unions, if you kind of ask them not to say that how much they like Medicare Advantage and how much it's good for them, only because it's so harmful for the rest of us.
They're not saying that.
Okay, good.
What they're not gonna do, unfortunately, is take a hard stance. And Stephen, you may know more about this than I do, because I'm not actively involved in negotiations. But I think it's important, that there doesn't seem to be opposition to Medicare Advantage at this point. So, but we
Yeah,
still have time to deal with that, and that's one of the things we're going to try to organize to do.
Yeah, that's
So-
obviously the CBAC organization, and I don't have any details on what their negotiating position is now. But if in fact you're right, and they are not pushing back against this, I couldn't agree more with Holly. These things,
Yeah.
this is terrible. It's privatized healthcare that is not good under any circumstances. And we as labor movement activists should be opposing that on principle, if nothing else, right?
Right.
Anyway.
Right.
So
And
speak-
basic, by the way, Holly, I'm sorry.
I'm
but
sorry, Bill, go
basically, I
ahead.
think what we really need to say is the reason for Medicare Advantage plans is to help privatize it, to make the Medicare trust fund go bankrupt, and then it will all be privatized. I think that's the message everybody has to get out.
Yeah.
Right. And on that note, we need to continue because we only have a half an hour left on the
Sorry.
managed care organizations coming back into our Husky, which is very detrimental. And I believe
Yep.
it's 15,000 people will lose their Husky because if this happens, in fact, I believe it's 15,000. Rep. Johnson, is that correct?
Well, we have more people now, on the Medicaid and the these and Medicaid than we've had because we've expanded access to Medicaid. So this is but let's go back for a second. One of the problems, I've also had a complex care committee on this issue as well, and I do want to continue analyzing it. And when we heard that the governor was interested in going back to the Medicaid managed care, all of us on MAPOC really had we just couldn't believe it, frankly. I mean, it is absolutely out there. And I was here, I remember before I even became a rep, and back in the day when Edith Prague was doing, I guess it was the initial MAPOC when it first started, and Governor Rowland actually went ahead and he changed it to Medicaid managed care, and it was about a year. And what happened is I remember Edith saying, "I don't know what happened here. We were supposed to save money and it's costing us 16 million or more a year now." And that was the beginning. And as we went on, we created, we had the MAPOC to oversee this because everybody was wondering, no one was getting the coverage under the Medicaid program, and people are wondering what's going on. The problem is when they negotiated with the Medicaid managed care insurance industry, as you are, I'm sure, all aware, whether it's Medicare Advantage that's privatized or whether it's the Medicaid managed care, These are private institutions. Their data is, it's private information. It's not anything that they share. They don't share the data. They don't share any of this information. And so we never got any information about who got coverage, what we had for people getting coverage. If people were turned down, they didn't really have much to be able to go on to get the appeals. They could get an appeal, of course, with through the hearing process at the Department of Social Services. But how many people in those circumstances will do that? So as we went forward, and when I was just starting, when I got elected for the first time, I thought, well, I'm going to be out of this Medicare, Medicaid stuff. And then they put me on the MAPOC committee. So, and at that time, what they did is we were working very hard to change how this was going on. There were two lawsuits to try and get the data, and they never gave us the data. They claimed that they'd give us the data. They never did. And so we worked very hard to create our own administrative process. It's excellent. It's less expensive. And we have the data. We have the information we need. We have more people covered. And it is stunning to me to think that anybody would even begin to imagine that we would be able to get anything out of the coverage with these Medicaid managed care situations. And so I go to women in government conferences, and one of the leaders in the women in government conference is the state representative, a Republican from Hawaii. And she can't figure out what's going on with the Medicaid managed care in Hawaii, okay? And they're having a hard time with people keeping covered and getting the things. And so I'm going back, working with the women in government group, because they are all over the country and people are having these issues. And we talk about healthcare a lot in women in government conferences. So I'm going to try and get more data and share how the litigation that we had back in the early 2000s to try and get the data, why and how we changed to our administrative service organizations that we control, we contract with, we get the data from. And the fact that here's another little piece of information on this. I went a few years after we did change to the administrative service organizations, and I went to a meeting in Baltimore with Eastern Regional Council of State Governments. And it was all about Medicaid. And one of the things I found out was that Maryland, or maybe it was Delaware. I'm sorry, one of the two states that had less than 1 million people. They had the Medicaid managed care, and they at that point in time were spending $8 billion a year, and we were spending $6 billion a year on our Medicaid, and we have 3.5 million people in this state. So that is just a very general thing. It's not drilling down into how many seniors and so on and so forth, but to have that kind of a $2 billion disparity seemed to me to be quite striking. So yeah, so we're working against that, and we will be continuously. One of the things in the complex care subcommittee with the approval of the human services chairs and public health committee chairs, we are working very hard to make sure that we take care of the aspect when we do this investigation that's going on, of making sure that the data is available. And how will we get the data from these private insurance companies that actually are, that's all about a secret. So secret stuff. So I don't know how we're going to do a comparative analysis with other states if it's all secret data.
Thank you, Rip Johnson. I am just learning now a little bit more. I'm doing a little bit of research, but it seems quite scary to me. And the other scary thing to me is, what if all of you wonderful representatives who are fighting for this and fighting against what supposedly is going to happen, what if you guys don't get reelected? I hope not, because, you know, I want you guys, how, you know, what do we do? How do we come to you still? What should we do? How can we support you? Because you are supporting the right way to do things and the just way to do things.
Well, take a look at the people on the MAPOC committee and make sure that they get their votes. I'm in a very blessed position. I don't have an opponent. So,
Oh,
so
oh,
I'm very,
that's wonderful.
my fourth time without an opponent.
Good
Uh,
for you.
but I mean, that's not true for everybody. And so take a look at who's on MAPOC, take a look at their remarks. I know the chairs of the thank you, Donna, I appreciate that. But you know, take a look at who's on the Medical Assistance Policy Oversight Council. Look at the people who are concerned about this with respect to you know, Public Health and the Human Services Committee, because those are the primary two committees that sit on the MAPOC committee.
Okay, thank
So,
you.
so take a look. We want to make sure we get, I know, you know, there are a number of people who are sit on there that might be in districts where they are newer. And I want to say it hasn't always been like this for me. I've been primaried a number of times and had some tough races, but I continued on and I really worked to try and make sure I help everybody and work with everybody in the district. And people know me from my background, you know, as working at legal services and before, and also at the Center for Medicare Advocacy. So I get a lot of calls from people outside the district, which I'm glad to help as well.
Thank you, Rep. Johnson. We really, really appreciate you very much.
Well,
Thank you.
thank you for doing the Medicare for All work, because that is something that we need to continue to talk about. And of course, it's going to be a federal change that's going to make access for everybody there. The other thing that I am trying to work on and is the trying to do something with the association plans, because they steal from the risk pool from the Affordable Care Act, which is regulated, and the risk plan and the association plans are ERISA plans. And so when you have ERISA plans, they're primarily regulated by the federal government, and it's very hard for the state to do any regulation. If you take a quick breeze through the Supreme Court cases on the issue, you'll see that the many people who analyze these have said that, well, maybe the Supreme Court overstepped its spot there by doing this regulation, because the ERISA plans were really set up to make sure that the pensions were fully funded when in the 60s and early 70s, when the big businesses weren't fully funding, and then they go, oh, sorry, we're going bankrupt, you're sorry about your pension. So they created ERISA, but they also included healthcare coverage in that. And so that is why it's the way it is today. And people do confuse ERISA with the Affordable Care Act, and that's another thing. They should really keep an eye on that, because we don't want to make a situation where the Affordable Care Act is going to be have a smaller risk pool, which will drive their costs up than the association plans, which they try to make a situation where they are they're saying, oh, we're going to provide health care to everybody with the association plans. And yeah, they're going to get premiums from everybody, but they're going to have high deductible plans. Those high deductible plans will put the actual coverage out of the reach of the person who's been spending the money on the premiums. So it's a win-win for the insurance industry again. And it's something that people have a hard time understanding, that we can't regulate the premiums. We can't regulate the deductibles, because those are regulated by ERISA on the federal level.
Thank you. I was just going to say,
Here's Sheldon. Yay.
Sheldon, do you have any comments, any questions?
I have a bunch of comments. The first thing is to thank Representative Johnson for fighting the good fight. I'm so glad you don't have to
Thank
you
you.
know, that's really helpful. A few things. One, Holly, you made a reference to people being cut off because of this. That's apples and oranges. there's the legislature did a couple terrible things this last session, one of which is to cut Husky A eligibility. And that's why they're being cut off. It has nothing to do with move to managed care. And that's already done, unfortunately. It'll be delayed about a year before it goes into effect because you get 1 year of extra benefits if you're a working person on Husky A under federal law, and then you're cut off. But yeah, that's what that is. It's not about move to managed care. Move to managed care will not cut anybody off, but what they have, their health insurance may be now worth a lot less because the access will be so much worse. And the two ways, as you heard it before, the two ways are a limited provider network and extensive use of prior authorization. There's everything is sort of one version of that or another. And there's other things like they, for example, are slow in paying the bills to providers, but all that does is drive providers out. And that's in the first category of too small provider network. So at the same time, access is bad. As Susan said, it's also more expensive. So as Edith was saying, what?
Yeah, I love that.
And the reason it's more expensive, let's just why is it more expensive? Well, think about it for 1 second. And Ellen explained this when she talked, the administrative costs for our Medicaid program, not talking about the eligibility process, but the actual healthcare delivery system is about 2.75%. Tiny. So it's a medical loss ratio of over 97%. Contrast that with an insurance company, which has to take at least 10 or 15% off the top just to run the bureaucracy and pay the exorbitant executive salaries, not to mention profit. So for the same services, it's got to, it's going to have to be paid more. And the way it works, because this is the way it worked, is that when we had them, was that the legislature would, in some years anyway, appropriate a modest increase and say, okay, we're going to give them a 2% increase this year. That's what they would say, the Appropriations Committee would say. And what would happen is that the Medicaid director would proceed to negotiate a much larger increase. What? And at the MAPOC, or back then called the Medicaid Managed Care Council, the people would say, legislators say, what happened here? We only appropriate so much. And David Perella, then the Medicaid director, would say, oh, woe is me, I'm a bad negotiator. Oh, well, and gives them more money. And the reason for that, so why is this process going on? It's because basically what happens once you have them, and it was a 12-year campaign to get rid of them. But once you have them, basically the bureaucrats like it because it's easier. Mm-hmm. Some executive people like it because the dollars are seemingly more reliable, more predictable. So bureaucrats like it, certain politicians like it, and they therefore sort of want to keep them. And if the MCOs are threatened to leave if they don't get that more money, they're gonna give them what they want, and they gave it to them. So all those reasons came together to conspire against us, and so we paid them more for less services. And the proof of that is exactly what Susan said, that after they were driven out, more providers signed up right away, not just the primary care people getting more money under the Affordable Care Act, but others, specialists, no more money for them, but they signed up because of less hassle. And the prior authorization process became much more professional, run through the non-risk ASOs without a dog in the fight. The last thing I wanted to comment on is tying together what was talked about at the beginning of the meeting just now and what we're talking about with Husky Managed Care. It is the same thing. Medicare Advantage versus traditional Medicare is more or less the same as capitated managed care insurance companies running Medicaid versus our managed fee-for-service system run directly by the state, contracting with non-risk ASOs. In both cases, healthcare is worse and more expensive through that kind of privatization. And I know this group is interested in Medicare for all, so it's easy to you all understand that healthcare is better delivered without insurance risk-based insurance companies doing it. Traditional Medicare, I think people may not know this, traditional Medicare, not the Medicare Advantage, is partly run by insurance companies, but only acting as non-risk ASOs who do certain tasks and don't have the huge administrative costs off the top. And they, most importantly, they're not at financial risk. They're just doing they're processing certain claims, sort of like our ASOs do in Medicare. But by running it that way, it is more efficient and higher quality. So I urge people, and I don't know if this is the plan for October for the press conference, but it's the same. It's the same issue. People can talk about it. It's the same problem that whenever for-profit insurance companies come in and say, oh, yes, we want to take risk, what they mean is we want to take a lot of money, deny claims, have a small network, and keep the difference. It's the same process with both managed care and Medicaid and Medicare Advantage. And by the way, it's a lot of the same companies. It's literally the same companies, United Healthcare, who does both things. Those are my comments. I'll shut up now.
Thank you, Sheldon. No, we always appreciate your comments. And I think I didn't mean to mix up the numbers with the different issues that were happening. My apologies. I tend to do that sometimes with numbers, but I know the number usually is correct. Does anyone else have any questions or comments for Rep. Johnson? I know that I appreciate you and your time and everything that you do. And the fact that you used to attend our meetings whenever you had a chance and you still do, we truly appreciate that. You were here when we first started, and there was lots and lots and lots of us on the meetings. And it was really appreciated to see you here and supporting us. And we've grown and we've ebbed and flowed, and you've always stuck with us and supported us. And we truly appreciate it very much.
Well, I appreciate your amazing kind words and your work. It's so important to have a group. We can't do anything at the Capitol without a group, and a group coming together to make sure that this change doesn't occur, and that we pick every single thing apart when they do their study. And I know Sheldon will be there helping us do that. His work is amazing, and I'm very, very pleased to see him here today. And so it's exactly what we need. And we need to continue to make sure that people understand what these private groups are doing and how they're taking us all for a big financial ride. So I do hope to make sure that we do the best we can to get that information out. And I do have a radio show and a podcast. So I would like to have people on there. If Sheldon would like to come on and talk about some of this, or you would like to come on and talk about Medicare for All to get more people involved. The time is now to get out there. What I do is I have the radio show. I've had it for about 25 years, and it's every Friday at 5 on WILI. And about 3 or 4 years ago, I started podcasting. And so I blast it on my website, and it goes on cable access, and it goes on YouTube. So I have that, and I think it might be time for us to take what you're doing and bring that forward to the people so that they understand, and we can get it done over and over again, maybe go around to different areas too, and have meetings with people on a face-to-face basis. So I'm willing to travel, and I'm willing to do this kind of thing because I really don't like to see the insurance industry destroy access to health care. And they've got the data, they're not willing to share it, but that they know that if they deny coverage, then people will usually just give up. And that will put an end to Medicare paying for things or private insurance paying for things. And if Medicaid managed care comes in, they'll do the same thing to the Medicaid people. And then people won't have the kind of life that we like to see people have and get over these illnesses that they have, that we have the capacity to cure. So it's a really important thing for us to cart this around, because they are gobbling everything up.
Would you please send an email to us with all of your information on your podcast and on your radio show and just on everything that you're doing so
Well, you
that
could actually go on my website at the Capitol, and every single week, my podcasts are there on my website.
so you
They're
do
all-
it through your Capitol website?
No, I do it through WYLI, AM and FM, 1400 on your radio dial, 95.3 FM. And so I have that, and they do the recordings and they do all that stuff, and they send it to me, and then I send it to my press agent, and he puts it on the, unless it's political, but anything having to do with policy, we put it right on, we blast it, and then it goes on my website. So you can take a look at all that. And all you have to do is contact me by email on these issues because it's my job. So it's not political. And it's it's not me running for office, it's me taking care of the people. So so that is what we could do. And then so go there, get that stuff, send me a note on my how to reach me, and then just give me dates and times and things when you might be available. And Sheldon or anybody here, if you're interested in doing some of this, that would be great. And just getting this out to people for the public. So, a lot of the weed stuff that we do in this chat, we probably would make it a little bit simpler for people. But, aside from that, just letting people know what the privatization is doing to the Medicare program, to the Medicaid program, and how it's going to limit access and cost more money. So that's the kind of thing that we need to try and do. So I'd love to continue to move this along and make sure we can cover the state.
Thank you so much. That's quite a generous offer. We will definitely be checking in with you for sure.
Very
Ron
good.
also has a cable show, so maybe you
Oh,
guys can be guests on each other's show.
sure, that'd be
Yeah,
fun.
I do Zoom interviews.
Do you?
I'm in New London, so it's Southeast
Fabulous.
Connecticut TV. And we've also been doing it for, I think, 20 years next month.
Sure. Well, this is great because one of the things the radio station hasn't done yet is Zoom. And we keep talking about we should do a Zoom, and our show actually is with my husband, Dennis O'Brien. Our show is videotaped, so we get the visual as well. And it gets onto the cable access, which, is really, that's another issue, but, we're losing that to
Oh,
the
man. I
corporate
wrote letters
monsters as well.
last
Yeah,
year or earlier in the year, but it was tough.
Mhm.
And it's true that people don't watch the public access the way they did 20 years ago, but they watch things on YouTube. I mean, it's a great resource, and then you can put the video anywhere.
Right. And that's why it's on YouTube. So we have the YouTube, but I talked to the people at Cable Access because, we have shows there too, separate shows from this, even though this is blasted over through them. But they need to get streaming done, and they're not streaming. And once we could get streaming in the cable industry here in Connecticut, and I don't know if they're doing it anywhere else, just haven't had time to research it, but we've had legislation we've tried to propose to get them to stream. And we need to be able to get them to stream, because if we did that, then we'd have that connection back in the community. And one of the things we've lost over the years, because we lost manufacturing and economics locally, we lost sense of community, which is what these things do. So getting the community back is one of the objectives, and it will please the radio station to know that they're being carted around the state. So, so yeah. But I'd love to do more of this because this is something that we all need to understand, and it's very complicated. But people start to hear things and they've had trouble with their access to coverage and so forth. Then maybe we can get more people to do that. And I think you were mentioning that you did have a lot of people who had been in contact here, and I'm wondering if we can make a list to just try and emphasize, because we don't have the data like we used to, So if that's something that you can do, that would be something also to take just think about that and see how we can address it.
So you would like a poll from our member list of who
Yes.
has been denied coverage from
Yeah.
an advantage plan?
Yeah. Yeah.
Okay, well, that's
Absolutely.
something that we can do.
Yes.
So
And
we
and
can
they can get
definitely,
their
yeah,
friends as well. I mean, so we
yeah,
can,
of
yeah,
course.
yeah.
Yeah, we
And
can do that. We can certainly do that. We
Mhm.
have the capabilities.
Mhm.
We can definitely chat offline because our technical guru person is not here tonight.
Right.
He takes care of that along with Rana. But
Sure.
he does all the social media part, and I think he does the Google Forms, but I'm learning.
Mhm.
So we would be more than happy to assist in that and any kind of actions that you think our membership could help with. Even though we don't have a lot of people that show up here for the meetings,
Mhm.
our group does take a lot of actions when called upon.
Good. Well, they might
yeah.
be, if you get it out to your group and just see what kind of course, it's not scientific, but it is something. It is some kind of data, and
Right.
so it's one way to maybe, so we'll see what it looks like in,
Okay.
a little time. Yeah.
No worries. We can certainly do that. And
Mhm.
I want to be respectful of everyone's time, but
Yeah.
are there any further questions or comments for State Rep Susan Johnson?
I'll just make one more comment. One of my ideas to deal with what Sheldon was talking about, the reductions in the Medicaid program, is to take all the low income population, all the human services thing, and propose to take them outside of the spending cap. And then the Republicans will go, oh, we can't, and even Democrats, some of them will go, oh, we can't do that. And I'm going to say, well, why don't we take a look at the fact that tax credits and tax breaks are expenditures as well, and add them to the spending cap. A little more research has to be done on that, but here's an idea on how to maybe change some of the rhetoric that we get, and how the spending cap is actually keeping people in poverty, hurting people, hurting our districts where we serve the regions. And I'm putting together how much we're hiding in costs that actually are paid for. For example, the Eversource for low-income people, the insurance cost for they have a little group of they have a money I'm blanking on the number on the
Money follows a person.
well, no, not money for the person. It's
No.
they have a fund. I'm sorry. They have a
Okay.
fund, and the insurance industry, the commissioner's office charges an X number of dollars to all the insurance providers, and they go into this fund. And ERISA plans don't have to pay. And if ERISA plans stop paying, and then it could put an end to the Connecticut regulated plans as well. So we have to start taking a look at these separate funds that are used to escape the utilization of using the guardrails as being a big positive thing. We have to really come out. So that's one of the things I'm working on as well. So just as a thought, and we'll see where it goes when we do the research, when we get all the numbers, but it's also special ed, it's all these other things that the state has been shifting the cost to towns, to the poor, just shifting. And I just got a note that they've taken almost $1 million from my school when they're supposed to be fully funding it in 2025. So, and I got one of the poorest districts in the state. So it's a constant struggle to make sure that because of the spending cap, these things are occurring. And we need to be able to expose the really bad things that the spending cap does and stop giving it the high praise that all the people who want to maintain poverty, keep people poor, that kind of thing, keep the districts poor where they don't have any, in the districts where they don't have any, say, housing, subsidized housing and so on. They don't want subsidized housing. They don't want these things. And so they want to keep everybody focused on with the spending cap. So, or the guardrails now. Anyway, that's a thought for tomorrow. And maybe some way to analyze this, but also if we can get the work out to everybody on the insurance and the healthcare stuff, maybe we can start a group, a statewide group understanding the harms and the expenses for every single person, every single town, for special education, for example, that people just don't think of because they don't understand the systems and the formulas.
Very true. Okay.
Okay.
Thank
My
you all
last 2
so
cents.
very much. No, that was wonderful. Thank you so much. It's just this, I'm over last session, and hopefully this session will be much better. Because
Okay.
I don't think I'm new to this. I'm a baby advocate, but that last one, that was brutal. You know, we thought we made some leeway the session before, and then they went back and got rid of it and cut it even worse. So I hope the force is with us this session, and we'll keep our fingers crossed. And
We have to change the rhetoric. In order to change the system, you have to come up with new ideas. That's why I think if
Yep.
we offer to say, hey, we love that, we think the guardrails, yeah, but we here, take out all the poverty programs and put in the tax cuts. See what they say.
There you go.
Expenditures.
Okay.
So it's a different way of thinking about it.
Good. That's a great idea. Thank you, Rep. Johnson. That's amazing. And thanks everybody for coming tonight. And for those of you who are going to be brave enough to watch the debate, I give you my best.
I have a debate party at Eastern Connecticut State University, and I'm on my way. So have a good night,
Okay.
everybody.
Good luck, everyone. Have
All
a
right.
wonderful evening. Thank you again.
Thank
Take
you.
care.